welcome to everyone that's joining us. Thank you. Wonderful, beautiful day. We'll try to keep this short. Today I'll be presenting on low back pain, or the topic of my aching back, quote unquote. My name is Samuel Jacob. I'm a physical medicine rehabilitation physician that has specialized in sports medicine, and I work in Valley Medical Group in the Department of Physical Medicine Rehab over here in Ridgewood, as well as in Wayne. So.
One more thing I'd like to add. Sorry, Dr. Jacob. If you have any questions throughout the presentation, please put them in the chat and we'll be sure to answer them at the end of the presentation. Thank
Correct.
you.
Thank you. All righty. So what are the things that we're going to be talking about today? So a little bit of summary. So first and foremost, we're just going to go with some statistics about low back pain, some of the risk factors of low back pain. We'll review some of the anatomy of the low back and then talk about common causes for pain, as well as common treatments and a little bit of prevention as well. And then, like Becky said, we'll leave all the questions for the tail end of our conversation. All right, so first and foremost, what is a physiatrist? I mentioned I'm a physical medicine and rehabilitation physician. What is that? Physical medicine rehabilitation physicians are also known as physiatrists. So what are we? Are we psychiatrists? Are we physical therapists? We are physicians who specialize in treating medical conditions that affect the brain, the spinal cord, nerves, bones, muscles, joints, ligaments, and tendons with the overwhelming focus on function. How can we get you to function? How can we get you to do the things that you need to do or want to do, limiting the things, focusing on the things that are limiting you and preventing you from doing those things? And we provide a variety of non-surgical options that could look like medications, physical therapy, injections, all those kinds of things. And this can help patients that either don't need surgery, don't want surgery, or can't get surgery for a variety of reasons. Now, a lot of physical medicine rehab physicians further go on to subspecialize in spinal cord injury, brain injury, pain medicine, sports medicine, such as myself, neuromuscular medicine, pediatric physical medicine rehab, as well as hospice and palliative care. So we often work in teams with a lot of other providers, typically with orthopedics and with neurology. And we also work very close in tandem with physical therapists, occupational therapists, speech therapists, dietitians, social work, a lot of those healthcare workers as well. So going into some of the statistics, getting into low back pain itself, just to see how common of a thing is, it is very common. About greater than 80% of the population will have low back pain at least once during their lifetime. In 2020 alone, low back pain affected 619 million people globally. That's about 10% of the world, and expected to be about 843 million by 2050. And that's due to both the growing amount of the population as well as the growing age of the population. So in the US, it is it is the single leading cause of disability worldwide below the age of 45. And in 2016, among 154 conditions, low back pain and neck pain had the highest healthcare spending in the US alone, estimating about $134 billion. It is the third most common reason for primary care visits. So it's clearly happening to a lot of us. We also noticed that during COVID-19, both the amount of low back pain as well as the intensity of low back pain increased. And this is due to a number of reasons. We're postulating that it could be due to decreased access to healthcare, a lot of people staying in and not being out during that timeline as well, a variety of different factors. So what are those risk factors? So age is unfortunately a risk factor when it comes to low back pain. We could see that as we continue age from the age of 18 to 29 up to 65 plus, there's a 28.4% from 18 to 29, and that increases to around 45% when we're older than 65. Women have a higher risk for low back pain than males do. We also notice that certain races do have a higher prevalence of low back pain, especially in Caucasian. We also notice that lower socioeconomic status can be a risk factor for low back pain. Obesity can be a risk factor of low back pain, as well as smoking, which is inflammatory, can cause low back pain. Poor sleep can definitely cause low back pain. Some other factors that could lead to it: job dissatisfaction, we have found to be a risk factor for low back pain, and mechanical work. So when you're handling these heavy loads, especially when it's repetitive postures, especially sitting for prolonged periods of time, repetitive bending forward and lifting heavy objects, a lot of tools that entail vibration, such as like jackhammers, construction vehicles where there might be a lot of vibration as well, and kneeling and squatting, especially greater than 1 hour per day. Stress, depression, anxiety have also been noted to be risk factors for low back pain. And we've actually found that there's a decreased risk for low back pain with more active people, especially those that are walking to work or cycling to work when there's not a very physical job that's required in general. So, just a little bit of anatomy of the low back. So, we like to divide the spine into different areas. So, we call the neck the cervical spine, the mid back the thoracic spine, and the low back, we call it the lumbar spine. So, if you could see my back, my mouse here, the lowest 5 segments of the spine here are called the lumbar spine. And then below that, there are more segments of your spine really called the sacrum, and then further below that, you have your coccyx, also known as your tailbone. So this is comprised of a variety of different structures. You have your bones, which are here. Those are the vertebrae. They're the ones that give support and structure and, withstand gravity. You have your muscles and ligaments that attach to these bones. They're the ones that allow for range of motion, you to be able to move. That could be bending forward, bending backward, twisting from side to side, or bending from side to side. Now, housed and protected by these bones, you have your nerve, you have your spinal cord, and then you have your nerve roots that exit out of here, and they go on to innervate and give sensation to your muscles as well as to your skins in your lower extremities. We also have the discs in between each of these bones, and they're like little cushions. So looking down here, this is what we could see as a normal X-ray. We'll kind of review that a little bit later as well. So what are some common causes for low back pain? What are all the things that could cause low back pain? So very commonly, almost like 80% of the time, we call it non-specific low back pain. That's when there's not really an attributable cause to the low back pain. Usually it goes away on its own, and it's oftentimes due to muscle strain or spasm or disc. Then there's spondylosis, spondylolysis, and spondylolisthesis. There's facet arthropathy, disc disease. There's radiculopathy, stenosis, cauda equina, compression fractures, and SI joint pain. We're going to go into these a little bit more during our discussion. What we're not going to talk about today as much, but also can cause low back pain, are other types of fractures other than compression fractures. Scoliosis can be a cause for low back pain, both in our adolescent population as well as in our elderly population. Tumors or cancers or malignancies, infections, and then inflammatory or autoimmune conditions such as rheumatoid arthritis or spondyloarthropathies. These are all things that we want to be aware of and keep in the back of our mind when we're assessing patients. So muscle strain or muscle spasm we see very commonly. This can be caused by overuse, trauma, abnormal postures, lifting something heavy out of the car, straining, sleeping awkwardly at bedtime, pulling a muscle, quote unquote. This can lead to kind of localized pain that hurts when you kind of push on it. It can lead to stiffness. It can lead to spasm. You could feel locked. You could feel like you're confined to the bed. You might have what we call decreased range of motion, where you're not able to maneuver as much as you were able to. You might be stuck in that kind of hunched forward position because once again, the muscles are spasm. You may have what we call myofascial trigger points, where sometimes where we push on one area of the muscle, the pain may even refer to other areas. And typically in this, you have a normal neurological exam, meaning the nerves aren't really affected. It's mostly affecting the muscle. It's more superficial. Oftentimes these resolve within a matter of, a few weeks. It can, require a little bit of anti-inflammatory, some gentle stretching, but there's nothing more concerning that's underlying. Now, lumbar spondylosis. Now, this is our fancy term for basically degenerative changes that happen to your low back, and this can be a normal degenerative process. You may get arthritis that happens with age as well as wear and tear. Think of a tire on a car. You know, after a certain number of miles, the tire gets a little bit worn, but there's nothing necessarily wrong with it. It could still run. A lot of patients may have this, but you might not be symptomatic of it. So what does this look like? You could get what we call osteophytes, disc space narrowing. You could get spurring. A lot of patients, a lot of people that might have had X-rays or MRIs, they might be familiar with some of these terms and they might be concerned. But just because you have it doesn't mean that you're necessarily symptomatic. So kind of looking over here to the left of our picture of the spine, you can see a good disc up top here. But as we go down here, you can see how that disc space gets narrowed. Sometimes you can lose the nice hydration that you get within the disc. You can notice that these bones are kind of more nice and squared off here, but as we go down below, you can see that there's additional spurring that happens. You see this lipping forward as well as backward. And then these holes where the nerves exit, you can see that there's this extra bones that can occur here, such as osteophytes or from facet arthritis that can cause some compression on that exiting nerve. So when it's typically just lumbar, when we're referring to lumbar spondylosis, it causes more of a local pain unless there's a nerve involved. It can cause some stiffness. Some patients might feel a crepitus or a cracking. There's not necessarily much we need to do unless it becomes symptomatic. You can see on our spine x-ray here to the side, you once again see that disc space narrowing. You see that spurring that's occurring here, as well as facet arthropathy, which we're going to get into just shortly. All right, spondylolysis and spondylolisthesis. Now, these are definitely a mouthful when it comes to all these terms: spondylosis, spondylolysis, spondylolisthesis. And what is the difference between all of these? So remember that spondylosis is just degeneration in the spine, just wear and tear that happens. Spondylolysis is when there can be a fracture, a small little fracture in one part of the bone, basically almost like the bridge between the front and the back of the bone. Now, when that small little fracture happens on both sides, both on your left side and the right side, that bridge in between, it could sometimes lead to some shifting forward. That's when we call it spondylolisthesis, when both of them. It usually happens at the lower lumbar level, at this L5 level, we call it, and it could happen for a variety of different reasons. Sometimes you're just born with this quote unquote defect that could be there within the bone. Some patients can get a degenerative spondylolysis, so that degenerative fracture. Sometimes
Dr. Jacob, I don't think we could hear you, or maybe my computer froze.
typically when it's symptomatic, it can cause a localized pain that occurs in your low back. That's worse with bending backwards, especially bending backwards and twisting, lying down. And sometimes we grade this spondylolisthesis by the degree that it's slipped forward. So down here we can see the different grades, and we grade it by each 25%. This is showing grades 1 through 4. Basically, grade 1 is from 0% to 25%, 2, 25% to 50%, 3, 50% to 75%, and then grade 4 up to 100%. And even there's that could be when it's completely off. And basically, usually when it's grade 3 and above, we could see that some of the nerves can be compressed because that's what's sitting right behind this bone here. Usually for grades 1 and 2, not much that we need to do. For grade 3, it's a little mixed. We can do a little bit of bracing, but if they're still symptomatic, or if you're having nerve symptoms shooting down to your legs, or if you're having a grade 4, we typically recommend surgical interventions. For this, we usually want what we call dynamic imaging. So if you think of a standard x-ray, if anyone's had it before, you're kind of just laying down or standing there, and you have your x-ray tech just taking a picture of you. For this image, we don't want you just laying down and standing. We want you bending forward and bending backwards as well to kind of see if there's any shift or instability if we are suspecting this. Oftentimes, when it's a low grade, there's not much that we need to do, especially if there's asymptomatic. We kind of just leave it as is. Now, facet arthritis. What are facets? Facets are joints that we have in the back. They're located at the very back. If you can see right here, they're the joints of the vertebrae from the upper vertebral segment to the lower vertebral segment, where they actually attach. So typically, that joint bears about maybe 33% of your weight. When there's arthritis, that could go up to 47%. And when there's what we call degenerative disc disease, it could bear up to 70% of the weight. That's a big shift in where the weight is being taken from the front to the back. Especially, this can hurt more when we're bending back and we're twisting. Now, going on to what we were saying before, a lot of times this can be asymptomatic. Just because it's there doesn't mean that it needs to bother you. But when it is symptomatic is when you notice that it's worse when you're bending back, especially rotating. It causes a little bit of local pain, but it could also cause referred pain or pain that shoots down, not just in that area, but down to your buttock, down to your thigh. It doesn't typically go to your calf or your leg, kind of usually typically stays a little bit above your knee. But it could definitely refer that pain out. As you could see on this top left picture, this is just a CAT scan of a facet joint right here. So usually when arthritis happens, as you know, a lot of people might know, when it happens to your fingers, when it happens to your knees, you can see that joint get a little bit bigger. So just like that, these joints get a little bit bigger. They get irritated. You could get those osteophytes. So you can kind of see right here, this facet joint looks a little bit bigger. You don't see much space in between it, especially down below. You could see that there's a little more spurring. Definitely looks a little bit bigger. Sometimes when it's big enough, or if it's irritated enough, it could irritate the nerve in front of it, or you could even get a little cyst that pops out of here. You could see this this side, which is actually the right side, compared to the left side right here, much smaller, much more normal. So oftentimes when it's not putting any pressure on the nerve, it just causes local symptoms. But if it's causing pressure on the nerve that sits there, it can radiate down to your leg. So herniated disc. So oftentimes patients will say, I have a herniated disc. What does that mean? So the disc, remember, that is that buffer, that shock absorber that sits in between the two vertebrae or the two bones. We oftentimes compare it to a jelly donut. It has a thick outer layer and a jelly-like inner layer. This is kind of just a bird's eye view of the disc itself. So oftentimes when you have a disc herniation and it's not pushing or compressing on anything, it can be completely asymptomatic. Nothing that we need to do. It can happen if you cough hard, if you sneeze. Some people say they popped out a disc lifting or bending or twisting or just randomly spontaneously. I've had patients that were surfing, caught a bad wave, and it resulted in a disc herniation. A lot we grade the types of herniations depending on what it looks like. Just imagine that jelly donut. Imagine just squeezing that jelly donut just slightly and it kind of spreads around equally on all corners. We call that more of a bulge. We call it more of a protrusion when it kind of sticks out on a little bit more on one side than it does on the other side, so not as evenly. That's our protrusion, where some of that area sticks out a little bit more than the other. We call it extrusion when that inner jelly-like substance, imagine the donut being squeezed enough that that jelly comes out. So when that jelly-like substance comes out, and it can potentially irritate the nerve. And we call it sequestered when a piece of that donut actually falls off and can actually sit in the canal. So oftentimes when it's a milder, when it's like a bulge, a protrusion, even extrusion, it can even resolve within a matter of 6 to 9 months. When it's sequestered, when that piece is off, sometimes it can be a little bit harder for it to go back in. Sometimes we can see it disintegrate on its own. Sometimes it does need surgical interventions to remove that little piece. So if it's just bulging and or a little like protruded, if there's a little tear in that outer layer, and it's not irritating the nerve, that could cause a little bit of local pain, meaning just in your back. If it's causing irritation on the nerve or compressing the nerve, then that's when you get that pain that shoots down your leg. And that kind of takes us into our next slide. We could see that different postures actually can put different pressure on the nerve. So this is just a study that was done comparing the pressure on the nerve compared to just standing. So at standing, you could see it's at 100%, 100 here. Now, compared to lying on your side, you could see there's a decrease in the pressure that's on a nerve. And then lying on your back, you could see is the lowest amount of pressure on your nerve. You could also see this when you're lying on your back and you have your feet up on a chair as well. And then we could see increases in that pressure when we're bending forward. So you could see that the pressure increases when we're bending forward, as well as when we're bending forward with added weights. When we're sitting, you could see that the pressure is higher from just standing versus sitting and then bending forward, it grows more. And then the most amount of pressure when we're sitting and bending forward with weights. This leads into our next slide from what I talked about as well. When there's pressure on the nerve, when there's pressure on the nerve and it's shooting down to our leg, that's what we call a radiculopathy, oftentimes referred to as the sciatica. So sciatica is when you do have that pinched nerve that's occurring, and it's shooting pain down a specific pathway. And which pathway it takes down the leg, as you can see on this image on the right side, depends on which nerve is being affected or what. It could be more than one nerve. So i.e. our L2 nerve can be in our groin, whereas our L5 or S1 nerve shoots all the way down the bottom of our leg, back of the calf, and to the bottom of the foot. So when that nerve is compressed, keep in mind the nerves are the highway system from your brain to your spinal cord to your muscles and to your skin. So what that nerve does, the nerve is responsible for your strength. It's responsible for sensing. So if that nerve is being compressed, you could have pain that is of burning, shocking, electric-like, or shooting quality in our back all the way down to our legs. It can lead to, if it's significant enough compression, it can lead to weakness of that muscle, the specific muscle that's related to that nerve. It could lead to numbness or lack of sensation in that area, and it could also sometimes lead to reflex changes. Usually this happens at what we call the L4-5 or the L5-S1 level. That's the lower level of our back. Now, spinal stenosis, what is stenosis? Stenosis is narrowing of the spine. In Greek, it actually means choking. So stenosis can occur because of multiple reasons. It could happen because of arthritis. It could happen because of a significant herniation. As you can see right here, this is what stenosis looks like. This is kind of a bird's eye view of our spinal canal. You have your spinal nerve roots in the center, and you could see where the nerves exit to the left and to the right. And you could see it's a little narrow. It's a little choked in the center, especially you can see it's open on this side right here, but then closed off on the right side here. You can see it's not as open as what we would typically want it to be. It's being pinched, and that could cause pain that's radiating down the legs. Now, in radiculopathy or disc herniation, we usually see that the pain is worse when we're bending forward. If you guys remember our last slide, that's when you have that more pressure on the nerve. In stenosis, it's usually worse when you're bending backwards. So often us doctors have what we think of when we're talking to our patients. We think of this shopping cart sign. Our patients will tell us they feel they feel pain when they're walking around, but when they go to the grocery store, when they put that pressure on the shopping cart and they lean forward, a lot of that pain goes away. And that's usually because of pain related to stenosis. The reason being that canal opens up a little bit more. There's less of that closing effect when you're bending forward, when you're leaning on like your sink counter washing your dishes, as opposed to just lying down or standing upright. Now, we have what we call piriformis syndrome as well. That's when the compression might not be necessarily due to something that's happening in your spine, but later on down the track. So you could see in this picture right here, we have this muscle that we call the piriformis in your buttock. Sometimes if that's spasmed or locked down, or it's tight, or there's lack of mobility there, it can tap down or pinch that sciatic nerve that lies below it, and sometimes that could shoot down the leg. So you might not necessarily have pain that's in your back shooting all the way down. It might be more in your buttock, and it could shoot and it could radiate down. Now, just because the herniation in our lumbar radiculopathy or stenosis it's the problem is happening in your back, doesn't mean that the pain always manifests the same exact way, where it's like classic way where it's in your back and shooting all the way down your legs. Oftentimes, I find that patients might have just pain localized in your back. And oftentimes, I have patients that come in and say, you know what, doc, I have burning that's just in my foot. Is it because of a foot problem? Or do you potentially have a pinched nerve that's coming from your back? And that's what we kind of tease out from your history and from your exam as well. So cauda equina. Now, this is more of a worrisome. This is what we look for. This is more of a worrisome diagnosis. Cauda equina and conus medullaris. That's when there's compression happening of those nerves, and especially spinal cord, a little bit higher. You could get injury to the spinal cord or those nerve roots that results in significant weakness. You get what we call this saddle anesthesia. Now, what does this mean? It means decreased sensation of this region, the inner aspect of your thighs, your buttocks, your pelvic area, so the region that you would sit on a saddle, quote unquote. You could get reflex changes, and you could get bowel and bladder issues, as well as imbalance with walking. You know what? I feel a little wonky when I'm walking. I'm urinating on myself. I'm soiling myself. Not necessarily constipation or holding in urine, but or going to the bathroom frequently, more so meaning I'm wetting myself and I didn't realize it. I'm soiling myself and I didn't realize it. Those are more worrisome findings for this kind of particular issues, especially the bowel bladder issues and the walking problems in regards to back pain. That's more of a reason to see a provider sooner or go immediately to the emergency department. That's something that you don't want to wait on. Now, compression fractures. Now, what are compression fractures? When we look at the back, we could see that our vertebrae have a specific height to them. We want them to be nice and thick. Compression fractures are, like it says, when that segment just gets compressed. You get a fracture. That could happen for a variety of reasons. It could be traumatic compression fractures. It could be osteoporotic compression fractures happening in osteoporosis or osteopenia. It could be pathologic. That's when there's something concerning going on, whether it be due to underlying malignancy or cancer. Those kinds of things, we want to be aware of those. Or sometimes we could see it with medications or certain conditions, prolonged steroid use. Whether it be for pulmonary condition or rheumatological conditions, long-term steroid use can increase your risk for compression fractures. Certain like hyperparathyroidism, where you're taking away some of that calcium from your spine, can increase your risk for that. So looking at this image right here, we see this nice height to these vertebral segments as we look over here and then down below here. But we see that this segment right here is just a little smushed in, it's compressed. This can result in some localized pain, pain that's just to pinpoint in the bony aspect of your mid back, and it can be worse with bending forward. Now, sometimes that compression fracture can result in a piece that shoots backward, and that could result in pain that shoots down our leg, just like we saw before. So when it's leading to significant, weakness, pain that's shooting down the leg, those types of things may go on to requiring surgical interventions, especially if it's causing weakness or urination or bowel issues. But oftentimes it just has a little bit of pain localized to that area. Oftentimes these are managed conservatively, meaning with a little bit of bracing for a short period of time, as well as a physical therapy program focusing a little bit more on extension or bending backward as opposed to bending forward. Now, sometimes when the pain, not weakness or any other type of thing, but when pain is still a limiting factor, we may refer you for what's called a kyphoplasty or vertebral plasty, where they may balloon a little bit of that vertebral segment and inject something like a cement in that segment, and that's to help with pain. Now, SI joint pain. Your sacroiliac joint is a joint that's basically from your spine to your hip region or your iliac region. It's a joint that we do see in the back that can often be symptomatic or painful, especially when it's a little too mobile. It could be like uncomfortable with positional changings, sitting down, changing from sitting down to standing up. We could also often see it during pregnancy, especially because there's a little bit of looser joints that happen in preparation for the delivery. And sometimes we could see this in certain inflammatory conditions or spondyloarthropathies, especially when it's in a younger patient that has a lot of morning stiffness. Um, so there's no there's no great way to diagnose this. We usually do it best with our physical exam as well as your history. And sometimes you may even require an injection to diagnose that it's actually happening there. And that's where your pain is originating from. And this is once again more of a local pain. There's no nerve that's involved, so there's no pain that's shooting down the leg. There's no numbness, tingling. There's no weakness. It's more just the pain and the discomfort that's in that area. Um, Workup and imaging. So oftentimes when you go to a doctor's office and you say, I'm having some back pain, they may start up with an X-ray, especially if you've had it for some time and it's not getting better. X-ray is usually our first image that we do get. X-ray is not going to show us everything, but it's really good. It'll show us what's going on with the bones. So we'll be able to see the bones. We'll be able to detect things like compression fractures, sometimes such, malignancies. We'll be able to detect that shifting forward or that shifting back or that instability that's sometimes seen there. And over here, all the way to our left, we could see a normal X-ray. We could sometimes get an idea of what the discs look like, meaning we could see a decent disc space here, but if that disc space is narrowed, I know that there's something going on with the disc. When we could see where the nerves exit in these holes right here. So if I see that there's less space here, I might know, okay, there could be some pinching of the nerve that could be responsible for our symptoms. Oftentimes we need to get this for baseline images for insurance reasons as well. Then we have our CT scan. CT scan is way better at detecting bony injuries and bony pathologies. This is our next image right here. We could see a CT scan where we have much better detection of the bone itself, detecting fractures, especially newer fractures that are there. But we might not get the best idea of tissue, but oftentimes this is a quick image that we'll get, especially if you're going to the emergency department and complaining about back pain. Oftentimes you'll end up getting a CT scan unless you have worrisome symptoms. Now, if you do have worrisome symptoms or you are having persistent back pain and we don't see anything on your x-ray, we usually more so get an MRI of your back. The reason we're able to better see the discs, we're able to better see the end of the spinal cord as well as the nerve roots, as well as anything that's going on with the discs that could be compressing the nerves or stenosis or those facets. We're able to get a better idea of the soft tissues, as you could see in comparing these two images. You can't see much of the discs here. You can't see much of the spinal cord here, but over here we get a much better image of that. We're able to much better detect, and this will give us further information. Sometimes it may be used to guide surgical procedures or spinal injection type procedures that need to be done. Now, not every patient can get an MRI. You might have certain like defibrillator or yeah, certain metallic components in your body or sometimes a gunshot wounds or anything else that might preclude you from getting an MRI. So we often do need to use the CT in order to get that image if we're unable to get an MRI. Another thing that is employed as well is something called an EMG or electromyography, also known as electromyography. It's a two-part test. One is a nerve conduction study as well as the electromyography. This is a way that we're able to study the nerves and how healthy they are and how healthy the muscles are. So if you're kind of just thinking of how an electrician tests the wires that might be in the wall and how much signal, how much conductivity, how much voltage you're getting from a particular outlet. Similarly, we're able to test the nerves. We're able to see how strong those nerves are, how fast are they sending that signal from different areas of the nerves, and how are the muscles responding? Is there any signs of muscle disease? Is there any signs of muscle wasting or atrophy or weakness that could be seen? So sometimes if our MRIs or CT scans are giving us some mixed findings, we'll employ the EMG to tell us, okay, is there something that's going on in the back, or is there something that's going on elsewhere, like further down the tract? Is there like a pinched nerve not in the back, but maybe behind the knee due to a cyst, or, somewhere else? Now, every now and then we'll also get some blood work, especially if we're, concerned for something inflammatory, things such as rheumatoid arthritis or another arthropathy, especially in, younger patients, if you're having joint pain in a lot of areas, to see, is there an underlying inflammatory component that could be causing this back pain, and do we need to address that? Now, when it comes to imaging, the most important thing to remember is a lot of things can happen due to normal wear and tear. You can get those disc space narrowing, you get osteophytes, you can get disc bulges that just happen over time, and they don't necessarily need to be symptomatic. We don't treat the image, we treat you as a patient. So if you're coming to us, oftentimes I have patients that are coming to me saying they're concerned, and they have because they were told they had a disc herniation, or they were told they had stenosis in their back, but they're completely asymptomatic. And I let them know, okay, I examine them. We make sure that they're doing well, that their muscles are doing well, their nerves are doing well. And, and after our physical exam, as long as everything else is okay, we let them know there's nothing that we necessarily need to do right now. There's nothing that you need to be concerned of. There was a study done in 2015 of around 3,000. It did a review of 3,000 participants. They gathered different studies together and pulled about 3,000 participants amongst different studies. And these were completely asymptomatic participants that had had imaging findings. And this is categorized by age. So we could see at a younger age, there was a 37% chance they were finding of disc degeneration. There's a percent chance of disc protrusion, fissures, facet degeneration, and that chance increases as we continue to age. But though that's there, it might not necessarily be symptomatic. So this is, once again, just harp on, we're not just treating the image, we're treating the patient. And oftentimes we'll see a patient might even be symptomatic, but there are multiple things that are present on their imaging. So it's us as physicians to figure out, okay, which is the responsible level? Which one is the one that might be irritating you the most based off our physical exam, based off what you're telling me on your history? And sometimes if there's more than one thing that could be causing you pain, it's a little bit of trial and error, addressing one thing, and if that doesn't work, addressing the next level as well. So immediate treatment. You strained your back, you injured your back. What's the first thing to do, barring any concerning symptoms, of course? There's a period of quote unquote relative rest. And I really say relative rest. We really don't want you to be down for the count for a long period of time. We really stress early tolerated range of motion and stretching as much as you're able to tolerate. Does this mean you have no period of rest at all? No. If that first day, if that back might be really aggravated, really like tacked down, really spasmed, it's okay to lie down for a little bit, take a moment as well, but try to do like some activities that aren't painful, things that don't cause pain, walking, gentle moving of the hips, gentle stretching, whatever you're able to tolerate is always good. A lot of patients always ask me about bracing. Sometimes it might be, this is outside of fractures, but it may be used in the interim, but we don't really like using it long term. The problem is that for patients that are using braces long term, we find that it actually weakens your core and weakens your back, because rather than using your muscles, using your core, using your back, you're more so relying on that brace for support. So it can lead to weakening of that muscle, which can further exacerbate back pain and then further put you more reliant on that brace itself. So we certainly do not recommend it, especially long terms. Is it okay situationally? You're going to lift a heavy object, you want that little extra support. That's certainly okay. And then going into what I was saying, avoiding strenuous activity, heavy impact stuff, especially in that initial spasm period. So we often employ a variety of treatment, and this can start with something such as medications. Tylenol, also known as acetaminophen, is usually pretty safe to take, barring any liver problems, such as taking like a Tylenol arthritis for pain is usually pretty effective. Anti-inflammatories. This can include something like an Advil, naproxen. Brand names include Aleve, ibuprofen, those kinds of things, or prescriptions such as meloxicam, Celebrex. This can also include something like a steroid or Medrol dose pack, prednisone. Those kinds of things help decrease inflammation, but you always want to make sure that it's okay with your physician that you're taking it. You don't want to be taking these things if you're on a blood thinner, if you have kidney disease, those kinds of things. We often employ muscle relaxers, especially more in that acute phase, meaning when the pain first happened. This can be such as like cyclobenzaprine, Valium, baclofen, methylcarbamol, those kinds of things. Oftentimes, it can tucker you out a little bit, so it can help if you have trouble sleeping at night. When nerves are involved in spinal stenosis, radiculopathy, when you get that nerve pain, burning, shooting, pins and needles type pain, we often employ a variety of nerve medications. A lot of patients might be familiar with gabapentin. We often use it. Duloxetine, also known as Cymbalta, Lyrica or pregabalin, amitriptyline. These are all medications that we employ, especially can be very beneficial, especially when there's a nerve pain and when there's stenosis that we can't necessarily change the anatomy of, but we could definitely change the symptoms of. Uh, Topical patches and gels, lidocaine patches, menthol patches, Voltaren gel or diclofenac gel topically, as well as CBD. And then sometimes some patients, especially for acute pain, might need low dose opioids. Especially for acute pain or fractures or those kinds of things. We want to be wary of especially using these things long term because it does have that addictive profile, that addictive side effect, and it can cause a variety of other things, constipation, etc. So on all of my patients, I stress the importance of, that early range motion exercises because that's what's going to make things better down the line. That's what's going to strengthen your muscles. So, that's what's going to strengthen your natural body brace. So really strengthening your core is going to be important because if you remember those facets, you get more pressure on the back, that could hurt more, that stenosis, that facet arthritis. So strengthening your core so something's pulling you a little more forward can be pretty important. Strengthening those hamstrings or addressing any type of hamstring spasm can be important. Low impact exercises, especially during the get-go or the beginning stages of that low back pain can be very important because, running on hard surfaces or on a hard treadmill or, something that involves heavy jumping, especially in the beginning stages of the back pain, isn't going to be too friendly. You're not going to like that too much. So what are modalities that are entailed, whether it be home exercises or physical therapy that we often, do send you to? Physical therapy can do things such as decompression or traction that could definitely help in some of those disc situations. That's when we're offloading some of that disc, putting a little bit of traction on that to decrease pressure. Ultrasound that's done at physical therapy gives a little bit of deeper heat, which can help. Dry needling can help a lot of patients, and something like a TENS unit, which provides stimulation so that your body is sensing that small little stimulation as opposed to pain. A lot of patients do find helpful as well. Now, when pain doesn't get better with some of our more conservative things or medications, that's when we consider employing a variety of injections. This can include trigger point injections. This is more muscle injections that we might do for like a myofascial trigger point, myofascial pain, like specific points of pain. We do it at the office. It can have lidocaine in it or lidocaine and steroid. SI joint injections that are done with ultrasound guidance or with X-ray guidance that could be done either in the office or in a special procedure room. and that's specifically for SI joint pain. For those disc herniations, and sometimes and for the stenosis, we often employ epidural steroid injections. A lot of people might have gotten epidural steroid injections. A lot more people might be familiar with epidural steroid injections, probably from labor, but this is completely different than during pregnancy. It's in a much more, controlled environment, and it's specifically targeting that area with a special X-ray machine. That's obviously not used during pregnancy. So that the pain management docs that are doing the injections know specifically where to go. This is not done in the office setting. It's more so done in a special procedure room, though the procedure only takes around 5-10 minutes itself. So they guide the injection based off your MRI or CT scan if you're unable to get an MRI directly into that area where that nerve might be irritated. Facet joint blocks or radio frequency ablations are also used for facet pain itself. This can entail a series of 3 different injections where the area is temporarily blocked twice just to confirm where it is. And then there's a radio frequency ablation that's done afterwards after the region is confirmed. That could potentially last 6 months or longer. That's where they kind of give a little bit of warming, burning to that sensory nerve alone so that it doesn't give that sensation of pain to facet joint pain. And that could be a good option for patients as it often doesn't involve steroid as well. So osteopathic manipulation, a lot of people might not know what osteopathic manipulation is. A lot of people may. DOs specifically employ osteopathic manipulation to find specific somatic dysfunctions that might be in the back or other areas of the body and to help address those. And just to specifically correct those regions of somatic dysfunctions, address specific sites of pain, address difficulties with range of motion or being stuck. A couple of other things that can really help with low back pain. Acupuncture can be pretty helpful, has been found to be beneficial in low back pain. Massage can be pretty helpful, especially when it's muscular pain that's happening. Chiropractic care, especially soft tissue manipulation of those areas. And yoga, whether it be regular yoga or chair yoga, and Tai Chi has been found to be very beneficial as well. Now, when do you go on to needing surgery? So surgery is recommended, for patients that don't improve with some of those conservative measures. You're not getting better with your anti-inflammatory medications or other medications. You're not getting better with physical therapy. You're not getting better with the injections. So then you might need a surgery, or for the patients that need a surgery sooner, because there might be weakness or those bowel bladder symptoms. There's something more concerning that's going on. So this can be a variety of different things. Sometimes patients get fusions that happen. Sometimes there could be microdiscectomies. There's a variety of different procedures that are done depending on what the specific site of pain is. It can be like a single level laminectomy that's done, and this is when there might be some compression or stenosis that's happening at a single level and kind of just removing kind of the roof off the hood is what I call it, so that there's no compression happening anymore. And when there's more than one level that's done, sometimes that entails like an effusion. Sometimes if it's just like a small, like a disc herniation that's causing irritation and it's significant enough or not improving enough, like something like a microdiscectomy can be employed just to remove part of that disc. Now, when should you get evaluated sooner? We kind of spread this out throughout the lecture, but when there's been a fall or a trauma, we typically want to get imaging sooner or examine you sooner. When there's weakness or numbness, we want to make sure that there's nothing concerning going on. When there's a fever, especially if there's recent travel with the fever, or there might be some illicit drug use associated with the fever, we want to make sure that there's no abscess or meningitis that could be going on. When you have difficulty walking or that urinary or bowel incontinence, you're wetting yourself, you're soiling yourself. When there's abnormal weight loss, we want to make sure that there's nothing malignant going on or if there's a history of cancer itself. What I did forget to mention real briefly going on into when it comes to the radiculopathy is another thing that could present just like this is actually shingles. So shingles can present in a similar pattern where it's going down one of these segments, and it could happen any of these levels, and you could get that burning, tingling, numbing, shocking pain. And it might not happen immediately, but you could also get that rash that you get that happens in that same distribution. So oftentimes patient gets the rash first and then they get these burning type symptoms, but sometimes you could actually get the the burning, the pain first, and then the rash only develops later. So be sure to let your provider, your physician know if you are having that rash as well, because then we'd want to treat you for shingles instead. So just going off into some, prevention. When it comes to low back, we always focus on strengthening the core muscle itself. We want to make sure that that core muscle is um, really strong so as to not put pressure, your pelvic girdle, your hamstrings. We often tell patients to regularly stretch to make sure you maintain that flexibility. Avoid poor sitting postures, especially if you're in a job or if you're in a position, you're a student, you're sitting for prolonged periods of times. I usually say, and growing in popularity, standing desks are getting a little bit better. Getting up every, couple of half every hour or two so that you can walk around. Smoking is obviously pro-inflammatory, so quitting smoking can definitely help. Lifting correctly, so not lifting from your back, but lifting with your knees and your buttocks, so you're putting less pressure on your back, can be very important. And then comfortable cushioned shoes goes a long way. So you want to make sure that your shoes aren't too worn. You want to make sure that they're appropriate for you, because even if there are, problems at the feet, that can translate all the way up to your back. Your body is a unit. Over to the side here, those 3 exercises, more so stretches that I like to tell all my patients, really simple to do during the day. Right when you wake up in the morning, bringing both knees up to your chest, gently holding that, bringing each individual knee, bringing like a single knee up to your chest, then the other knee to your chest. Doing this piriformis stretch that you see on the bottom there, it's what I also like to call it a figure four stretch, because your legs look like a figure four, and then you bring your knee up to your chest to stretch that piriformis, stretch that back, and a little bit of that in the middle there, you see a little bit of what we call that lumbar twist, where we just get a little bit of range of motion. Obviously, staying away from any, positions or postures or stretches that are causing you pain, but just gentle. A lot of patients ask me, what is the best bed to get? What is the best mattress? Should I get this new mattress? Oh, this costs X amount. Um, there might not be one best mattress that's, best for everyone. Usually some of the studies have found that a medium to firm mattress have been better, and usually sleeping, between your back and your side have been better, as opposed to sleeping on your stomach. So transitioning from your back side and keeping maybe a pillow between your knees has found to be more beneficial for low back pain. Um, and that is it for my conversation today. I'm sorry. I hope I didn't go overboard. Like I said, this is just some of my contact information. If you ever wanted to reach out for anything outside this lecture or get in touch with us, we're located in the Ridgewood and the Wayne office. But I'll definitely look through the chat for any questions that you have right now.